Hi, good afternoon, everyone. Thank you for joining us today. We're very excited to have you all here. I would like to first introduce myself. My name is Sandra Salcedo, and I'm a clinical dietitian and a certified lactation educator counselor from San Diego. I have been the CF dietitian at our UCSD Rady's Children's Hospital CF Center for 20 years. I'm also the CFQI coordinator. And in addition to CF, I've also been working at Rady Children's Hospital feeding team for over 10 years. I'd like to thank the foundation for asking us to participate in this program. This is a topic that I really hold dear to my heart. In addition to being a dietitian, I'm also a mom of 2 children, and one of them has severe oral aversion and feeding difficulties. And so I've actually been in the trenches with some of these parents. So it's very good. I would also like to introduce Dr. Sabina Sabaral. She is the director of the CFGI program at Boston Children's Hospital. She was a Digest awardee. She cares for patients with CF-related illnesses ranging from constipation, exocrine pancreatic insufficiency, to CF-related liver disease. She works with the CF Center on Quality Improvement projects involving nutrition and growth in CF patients. And she is the site PI for the BEGIN study. Lastly, I would like to introduce Dr. Nancy Sullivan. She is a pediatric psychologist in the Division of Developmental Medicine at Boston Children's Hospital. She's an assistant professor of psychology and pediatrics at Harvard Medical School. Dr. Sullivan specializes in assessing and treating children with complex medical disorders and other neurodevelopment disorders, with a special emphasis on treating restrictive eating for children. She's worked in growth and nutrition program for over 15 years. And now she opened her own program for healthy eating, in the Developmental Medicine Center. One housekeeping thing, we're gonna take questions at the end, and I know that we're using the mobile app. Just want to make sure that you please submit it to the question part of that mobile app. I know that I think it automatically goes to the discussion part, so if you can go to the questions so it's easier for us to keep track of your questions, we'd appreciate that. And with that, I'll leave you to Dr. Sabaral.
Thank you, Sandy. So we are, as a team, going to talk about feeding challenges, both from a medical and behavioral standpoint. Closer? Okay. Can you guys hear me? Is that okay? Okay, thank you. And we have no relationships to disclose related to our presentation today. The objectives of our talk are going to be to review medical factors that can lead to feeding problems in patients with CF. Particularly, we're focused on the toddler school-age population in this talk, to discuss how the feeding difficulties could then impact nutritional outcomes, and to discuss strategies for assessing and addressing feeding behavior, and to encourage the development of positive eating. I'm going to start by talking about the medical factors that relate to feeding issues, how we think about an approach and look for example, red flags, before I move to then have my fellow speakers talk about nutritional and behavioral issues around feeding. In looking at the CF Foundation guidelines, in 2008, specifically looking at nutrition guidelines as it relates to children and adults with CF, they put forth the use of a combined behavioral and nutritional intervention for children's ages 1 through 12 that had growth deficit. The following year, in looking at the guidelines focused on the management of infants with CF, again, there's an emphasis on positive feeding behaviors being encouraged in infancy, and more of an intensive treatment approach for both nutrition as well as behavioral intervention in children ages 1 through 12. And then more recently in 2016, in guidelines that the foundation issued for preschoolers, more intensive management for children at nutritional risk really came to the forefront, with all families being regularly assessed for presence of mealtime behavior challenges and also being provided proactive behavioral assistance when needed. Studies have reported that children with CF are at higher risk for feeding difficulties, and this has been shown to significantly impact nutritional outcomes. There was a study in 2003 that was done in the UK where they basically looked at these practices, and feeding problems were the most common area of difficulty cited by parents in that cohort. 70% indicated that CF made them more anxious about food intake, and almost a third reported feeling unhappy about their child's growth. But interestingly, only 6.5% in that cohort requested intervention. And feeding problems were noted in CF in this study to have a longer duration than just, say, toddler picky eating in non-CF patients. This really indicated that parents are aware of a problem, but they may not be aware of the impact that feeding problems can have on nutrition down the line. Again, looking at the clinical practice guidelines for the foundation, specifically at preschoolers, they've put forth an algorithm looking at physical exam, history, and things like dietary interventions, pancreatic enzyme replacement therapy adherence, use of supplements, addition of acid blockers, for example, and things that we would normally do as practitioners. But if you look under the diet history column, there's also mention of assessing mealtime. Is it longer than 15 minutes, for example? And also inquiring if there are behaviors that the children exhibit at mealtime that would make it difficult to meet their energy goals. Further, in the social/psych column, they also talk about parental anxiety, depression, and understanding the importance of family dynamics in the assessment of feeding and ultimately nutritional outcomes in this patient population. Our case presentation involves a 5-year-old male who we saw at Boston Children's Hospital who had CF. He was Delta F508 homozygous. He had exocrine pancreatic insufficiency and constipation and presented with poor weight gain. He complained not at all of abdominal pain or any sorts of gastroesophageal reflux symptoms or dyspepsia. He was noted to be not toilet trained at the age of 5. He was taking Miralax, and this helped really with stools for him in terms of frequency and consistency. He vomits when he has a tantrum, according to his parents, or when he's resisting trying new foods, but in general does not vomit, and had no other red flag signs such as blood in the stool, things like diarrhea or mouth sores, which could indicate an inflammatory condition. In terms of dietary recall, he continues to drink from a bottle and not a cup at the age of 5, and he drinks over 20 ounces of whole milk per day. He skips breakfast, has 4 snacks, and 1 meal. So parents felt that usually dinner was what they would describe as a solid meal for him, but he was largely grazing, snacking, and wouldn't eat in the morning. And he had tried Pediasure as a toddler, not with consistent success. He was drinking mostly whole milk, and now is on Boost Kids Essentials and currently takes 2 bottles of that per day. In terms of his other history, he was born early at 36 weeks. Prenatal CF status was known. There was no irritability or colic, no known milk protein intolerance, no meconium ileus at birth. Mother had tried to breastfeed but had a low supply and was followed for poor weight gain by the CF Center in infancy, treated for infant reflux, for example, with ranitidine. He was admitted at the time that we saw him for 2 inpatient pulmonary exacerbations in the first 5 years of his life. There was no CF in the family and no known GI history that would be significant for any inflammatory process or celiac disease, no known anxiety or depression. Social history, interestingly, showed a twin sister who did not have CF and is actually socially and developmentally on target. And he lives in a family who is from Bangladesh. The mother does not speak English. Father speaks some English. And although we did our appointments always with an interpreter, it was interesting to see that mostly the father would speak during the visits more than the mother, even though she was the caregiver. And over time, we really learned a lot about some of the habits, such as like force feeding and things that were going on at home that were really characterizing his feeding issues. His weight, height, and BMI Z-scores were low, and his absolute BMI was at the 1.6 percentile when we saw him on the CDC curve. In terms of his medical workup, negative for celiac, his liver panel was fine, thyroid panel was negative. He had some mild vitamin D deficiency and had mild iron deficiency, which was thought to be related to his excessive milk intake. He was at that point referred to what we call growth and nutrition, which is a specialized program within our GI division at Boston Children's Hospital to focus on nutrition, psychology, as well as like feeding issues, so with speech and language pathology. So it's a multidisciplinary program that works very intensely with patients that present in this way. I do want to talk about the definition of feeding disorder, which really was proposed in 2016 to take more of a collaborative approach to how we see feeding disorder so that we can understand the different aspects of the care team and how that would positively impact these patients. A disturbance in oral intake of nutrient inappropriate for age, lasting at least 2 weeks, associated with one or more of the following is really the definition that we're using. 1, medical dysfunction, so things like cardiorespiratory issues, wild feeding, aspiration, or history of pneumonia. 2, nutritional dysfunction, so malnutrition or specific nutrient-related deficiencies from decreased dietary diversity, reliance on enteral feeds or oral supplements. 3, feeding skill dysfunction, so need for things like texture modification or use of different positions, equipment, different modified feeding strategies. Very importantly, psychosocial dysfunction, so avoidance behaviors with feeding or being fed exhibited by the patient, but also inappropriate caregiver management and subsequent disruption of caregiver-child relationships and social functioning related to feeding. And importantly, there should be an absence of cognitive processes consistent with eating disorders and pattern of oral intake, not due to a lack of food or congruent with any cultural norm. The role of the gastroenterologist really is to assess current nutritional status, risk, and we use current, like what is presented to us at the time that we see the patient, of their weight, their height, weight for length or BMI depending on age, and also just growth trends over time and looking at percentile changes over time. We refer to dietitians who fortunately are a very integral part of our CF teams to really determine what calorie and protein intake should be and to set an energy intake goal, both just that's age appropriate as well as in terms of any catch-up growth. And to rule out other organic causes of feeding difficulty and poor weight gain, which I'm going to talk about. And also to assess for any vitamin mineral deficiency, just using previous labs and looking at vitamin supplementation adherence as well. We know very well as a care team for patients with CF the importance of nutrition and cystic fibrosis. We know that there's a definite correlation between BMI and FEV1 predicted. This is the most recent CF Foundation patient registry from 2020 on looking at this chart. And even if there's been some shifts in terms of where we may want the BMI to ultimately be at this point as it relates to FEV1, we do know that that correlation still exists. Weight is also a predictor of later outcomes. Elizabeth Yen, in a study in 2013, looked at weight for age at 4 years to see how it relates to patients in adolescence, and really found that they achieve greater height, better pulmonary function, fewer complications related to CF, and improved survival through age 18 years of age. Nutrition supports optimal pulmonary function and prolongs life. Malabsorption, increased energy needs, and reduced appetite are all factors that cause essentially nutritional dysfunction. There's a close correlation, as we just mentioned, between PFT results and nutritional status, but it's really unclear which causes which. The pathophysiology of nutritional failure is really multifactorial. There's an insufficient production of pancreatic enzymes, which leads to fat malabsorption in patients with CF who have exocrine pancreatic insufficiency. This can be exacerbated by bile salt abnormalities if they're things like concurrent liver disease, for example. There's progressive pulmonary infection, bronchiectasis, and increased calorie needs, chronic infection, which can lead to reduced appetite as well as a catabolic state, and other factors that can affect nutrition, such as diabetes, altered GI motility, which we know that dysmotility worsens as CF patients age, and other factors and disease states such as small bowel bacterial overgrowth or SIBO, gastroesophageal reflux, which we know happens at a higher prevalence in patients with CF for a variety of factors, and intestinal obstructive processes like constipation and distal intestinal obstruction syndrome. We also know from a physiologic standpoint that there's a more acidic luminal environment in CF. The mucus is more viscous, that there's gut microbiome dysbiosis that has been described, a low-grade intestinal inflammation related to the CFTR dysfunction, and increased intestinal permeability. We also know that there is an influence from having exocrine pancreatic insufficiency, but because this is largely treated with enzyme replacement therapy, the exact influence is unknown. But this is all to say that there are things going on that can then lead to other symptoms in the body, certainly that can lead to feeding dysfunction as well. The GALAXY study was a longitudinal multi-center study to really determine patient-reported prevalence of GI symptoms, to determine the frequency and variation over a 1-month interval in patients greater than 2 years of age, and really to understand the management of these symptoms. And the cohort was taken from community voice from the CF community, and also CF providers were surveyed for this study as well. The results really showed that GI symptoms were significantly impact CF quality of life scores. The most common abdominal symptoms that were noted were bloating, fullness, early satiety, postprandial pain, constipation both in the form of straining and incomplete bowel movements, and over 20% of patients also reported upper GI tract symptoms, like more relating to the stomach and esophagus, more like dyspepsia symptoms. Constipation, we know, is a significant factor related to feeding difficulties in general, and even in patients that do not have CF. It's been found in studies to be common in the setting of picky eating related to low fiber intake and low intake of water. We know in CF that fluid and fiber intake are not necessarily correlated with constipation, that there are other reasons that these patients have worsening constipation, but certainly those sorts of behaviors can make this worse, and we know that constipation can impact up to half of all patients with CF, and so that's a very significant factor to pay attention to in this population. The red flags for feeding difficulties from a GI standpoint are really growth flattening or actually losing weight and not just gaining at a less accelerated pace. Dysphagia, choking, frank nutrient deficiencies, vomiting, apparent postprandial pain, things like skin eczema, which can be signs of nutritional deficiency or allergy, and other symptoms like diarrhea. And then things like prolonged meal times, and meal times being very stressful, lack of appropriate independent feeding, especially as these kids get older, nocturnal feeding, failure to progress to advanced textures, things like cardiorespiratory symptoms, and then medical history things like extreme prematurity, neurodevelopmental genetic issues, autism, eosinophilic and allergic diseases, as well as things like celiac disease. And we've actually had patients that I feel like we've diagnosed to be on the spectrum who, because they have presented with feeding difficulties, just anecdotally in our practice. So just to conclude, before we move on to the nutritional and behavioral segments of our talk, again, citing the consensus guidelines by Lahiri in 2016, when do you really want to consider referrals or consultations for patients when it really seems to move beyond just picky eating? And I think that's really, with regards to GI, related to ongoing malabsorption, even with optimization of enzyme therapy, concern for moderate to severe constipation, reflux symptoms, things like dysmotility, SIBO, or concerns for other diseases such as celiac disease or eosinophilic esophagitis. And then there's also importance to thinking about other parts of the team, which we're going to talk about. Nutrition, I feel like fortunately is always is working with these patients regularly, which is wonderful. But family stress, things that are impacting the patient caregiver dynamic, would lead you to also refer to more behavioral treatment routes. Feeding itself being abnormal in some way would make you think more about speech and language pathology. So it's important to just think about this team approach. And then other things such as concern for diabetes or any kind of CF metabolic disease would lead us to think more about, for example, referring to other parts of our team medically, such as endocrinology. So I think with that, I'm just going to turn the mic over to Sandy to talk more about the impact of feeding difficulties on nutritional outcomes.
So my role is to review the impact of feeding difficulties on nutrition outcomes. I know it's a busy slide, but I think it's actually a pretty great reference. Human eating behavior develops rapidly from infancy to school age, and the slide helps provide helpful information regarding typical feeding milestones. Age-appropriate mastery of feeding milestones include liquid by breast or bottle from birth, eating pureed foods, and removing foods from the spoon by 4 to 7 months, eating soft table foods, 18 to 15 months, and drinking from a cup and eating foods requiring chewing, starting around 8 months. In typical development, we make a distinction between eating and feeding. Feeding is an interaction between a child and caregiver. In young children, feeding is mainly dependent on parents and caregivers. And eating comprises of actions regarding nutritional intake via mouth that is performed only by the child. The relationship between caregiver and child accounts for each to hold special responsibilities, and Dr. Sullivan will go into this in more detail. When this coordinated process is impacted, feeding difficulties can develop, which may lead to considerable stress for both parent and child, and may lead to problems in overall dietary intake, which may adversely impact health and developmental outcomes. Studies show that picky eating is associated with greater risk of being underweight and having poor growth. In CF, we know that undernutrition affects respiratory muscle function, impairs growth, cognitive development, immunity, and lowers quality of life and shortens life expectancy. Feeding difficulties can lead to lower energy and protein intake. For example, Dr. Powers and colleagues in 2002 found that toddlers and preschool children with CF and pancreatic insufficiency had been observed to have difficulties meeting energy needs. And earlier, in a study in 1994, there was a negative association between caloric intake and the number of problematic feeding behaviors in children with CF. Studies have also found lower intakes of fruits, vegetables, whole grains, meat, and fish, as well as lower intakes of macronutrients such as vitamin A, D, E, calcium, iron, and zinc. And vitamins, the vitamins and minerals noted here, they are of special interest to our CF population. And if we recall back to our case study, we did know that some of these deficiencies were evident in the child. So studies indicate long-term effects on diet and point to the important role for early intervention. So part of this is also to look at the role of the dietitian. We evaluate growth and measurements. We like our numbers and our calculators. So we make sure we look at the weight, the length, height, head circumferences, weight for length or BMI, mid-upper arm circumference, determine adequacy of growth and trends over time, and evaluate changes in percentiles. Going back to our case study, we see that that our child's BMI was consistent with moderate malnutrition with a BMI Z-score below 2. And then this arrow points at the period of time when the child was actually referred to GI nutrition and the improvement that subsequently occurred. We continue, as part of our assessment, we also look at bowel movements, the habits, patterns, consistency, and colors. The Bristol stool scale is very helpful. And in fact, I remember that we actually made copies of it and posted it all over our rooms. And that actually helped us identify more constipation than we ever thought was actually occurring in the clinic. Because while the parent would say, oh, no, it's soft, and it's like, no, I had one this morning, Mom. They would actually reveal more information than what the parent actually knew at the time. We also looked at abdominal distension and pain, pancreatic enzyme replacement therapy, adherence. Are they using it consistently before meals and snacks? Or fat-containing beverages, such as milk or shakes or oral supplements. And I think sometimes this happens a lot during toddlerhood, where there's that transition from either breast milk or bottle feeding and then having a toddler meal, and then the family forgetting maybe a little bit that milk requires enzymes. So I'm making sure that I see a lot of nods that it's happening toddlerhood, and with families, there's like, oh yeah, and they had milk. Oh, I forgot to give the enzymes. Oh, so it's one of those things. Also, we look at medications that impact appetite. Some medications, if they have another diagnosis like ADHD, can impact the appetite negatively, or sometimes they've already been prescribed an appetite stimulant. But is it being used appropriately? I know that some families are very hesitant at times to start the medication. They do have it prescribed, but maybe they'll use it once or twice a week, and then they kind of gradually go into actually using it as it was prescribed with mild and gentle encouragement from clinic. Now, the use of CFTR modulator therapy, to date, we don't have data available on how the CFTR modulators will impact feedings, but anecdotally, we found that in our clinics, CF families have decreased stress level in response to improved nutritional status. And now that modulators are being approved for younger age groups, that may actually also be an additional silver lining that we have. If families are in fact experiencing lower stress level, this may help with the child's eating behavior. Look at the feeding history. Let's look back when you have families who do come to see you, and ask about the early feeding episodes. How was it that the child interacted with breast or bottle feedings? And when were enzymes, and when enzymes and salt were introduced, how did that go? I know that sometimes I do get a lot of, I actually had a case where a family came in and, I actually feel like we should take advantage of the 2-hour-long visits, because sometimes there's a feeding involved. And so I actually had the experience to see a family use the enzymes, but they grabbed the child and then they just started, because the child didn't want to eat it. So, just kind of gentle reminders, behaviors that can actually worsen the situation. So keep that in mind. If you can, I know that all our clinic members, if there's a feeding happening, Sandy, there's a feeding going on. So I could go in, I need to get this or anything, just to kind of observe a little bit. And also talk about like the introduction of complementary foods. How was it? Did they enjoy it? And how was the response to other feeding transitions? Look at the current feeding status. We're really good at assessing a 24-hour recall most of the time, and look at the appropriateness of that, of the diet. Look at food allergies or intolerances, food selectivity, such as food refusal or sensitivities to certain taste, texture, odor, color, temperature, food preferences and food JAGs, the feeding schedule, the timing of the meals, the frequency of the meals, length of meals. And I know that earlier on, Dr. Powerzen's colleagues did identify that children with CF tend to have longer meal times. And also who participates in the meal. Do caregivers, siblings, or does the child eat alone? And I've noticed that not everybody, but there are some families who are so stressed by the whole situation that they actually have the child who has the feeding difficulty eat by themselves. And, so they are isolated, and you miss that whole role modeling aspect of things. So that's something to kind of look into as well. And then other factors that may influence diet and feeding, such as cultural. In our case study presented, the CF care team did identify that there were some cultural feeding practices that could have aggravated the feeding process of this child when they were being force-fed. Determining the calorie and protein needs for growth. And going back, dietitians do like to calculate. I think that we're attached to our calculator. I'm probably going to be buried with my calculator next to me. But it's actually, something that we're numbers oriented. And looking at setting up calorie goals. And there are some, reports saying, recommend 10 to 20% above baseline and continue to use incremental adjustments as needed to achieve weight gain. We've got to turn that into a practical recommendation and guidance, like add an extra snack here or an extra food group or an extra spread of something into the meal. Assess for vitamins and mineral deficiencies. Look at the diet and the dietary sources. And labs, current vitamins, supplementation and adherence to that. Also look at the proper use of oral supplements. Are they being offered at the end of the meal or snack in order to avoid displacement of calories from food? And I do often recommend families, even before we start oral supplements, not to use it as a meal, snack, or replacement. Sometimes we choose the path of least resistance, and I know that oftentimes families would say, okay, you're not going to have your lunch here, just have a boost or have an Ensure. And when things are going well and they're improving and their weights are going up, it's important also to discontinue it when it's no longer needed. We look at gastrostomy tubes as well. Optimize the use of G2 feedings if indicated, and revisit the conversation with a family about its indication or need. And we're not going to talk about this, but I did put the reference up there if you guys want to look at those guidelines. Additionally, highlight principles of an age-appropriate diet. Consider the developmental status, not only if they're 2, they're eating like a 2-year-old, so also look at those factors. And age-appropriate portions. MyPlate.gov has helped our institution actually come up with this wonderful handout of portion sizes, so I referred you to that. And normalize meals and feeding patterns for age. I know sometimes, and I see this most commonly in first-time parents, maybe they grew up with 3 square meals a day, and they have a 2-year-old and they're giving them 3 square meals a day. And so, we talk about there's also snacks, those sort of things that could be incorporated. And help parents identify preferred foods. This is actually an exercise that I do in clinic. I ask them to briefly just kind of develop this food list, and I title it the yes foods, the sometimes foods, and the future foods. And this gives the parents okay, these are for my for sure foods. I got this. This is sometimes the sometimes foods. And this is what I really hope that my child would eat, is the future foods. And use some of these yes foods as anchor foods to build meals around. And because diet quality counts with limited variety. Do they have a milk, something from the dairy group, the grain, a fruit or vegetable, or a protein? And highlight that, even in spite of all the selective eating and pickiness that's been going on, they actually got a few things down. And they should be proud of that. We also have great handouts available through the CF Education Resource Guide, and so I listed some of these handouts here. Many of them are available online, such as the food refusal in children with CF through the CF Trust, and the feeding the 4 to 7-year-old, 8 to 12, and 12 to 4-month-old. You can just Google them directly, but they're available. And then when indicated, I think we're pretty good about knowing how to counsel on a high-calorie diet for most of us who've been doing this for a few years. And I want to refer you back to some additional handouts that are available through the CF Foundation. On the age-specific nutrition handouts, there's an energy booster card, there's a grab and go, and then there's some really good websites. Sometimes when I'm in the clinic office, I bring up these websites and I say, oh, look, here's some recipes, and these are some age-appropriate ones, and this is based on meal. And even the kidshealth.org has even like a guide how to get a toddler in the kitchen, how to get, depending on the age group. So they're actually pretty nice. And lastly, we know that feeding difficulties is they're multifactorial in nature. And thus it necessitates a multidisciplinary team assessment. So we know that in CF, a combination of behavioral and nutritional counseling has been found to be more effective in improving energy intake. And that has also occurred in non-CF groups. And in one study, they actually found that this combination, I think it was published in 2017, actually prevented some children, again non-CF, but from getting a G-tube. So it's very important. And with that, I hand this over to Dr. Sullivan.
I just want to say thank you again for having me here. It's really a pleasure to be with you all, and really has been exciting for me to be part of this. And we're here as three of us together in a multidisciplinary setting, and that's how we prefer to work. But I realize there's probably some of you out there who don't have the luxury of having a psychologist like myself on your team. So I'm hoping that this talk will give you a little bit of an orientation of what it might be like to integrate a psychologist or a behavioral person into your team, but also some of these strategies and things that I'm going to be discussing are things that you as a dietitian or a GI doctor or other health professional can integrate into your practice. So I'm hoping that that will be something that you can take pieces of this from, and then also resources as well. So going back to our case presentation, I'm going to talk a little bit more in depth about the assessment that we would do for this child, and really looking more closely at some of the pieces that are important to me as a psychologist. And obviously all the medical aspects are very, very important. But was very important about this case is understanding the cultural contextualization of the feeding problem. And that this was a family that was coming from outside the US in a place where traditionally in the last 100 years or so, infant mortality could be very high, particularly for an undernourished child. So feeding practices within that particular culture could be very aggressive. That things that here in the US you might not see feeding a child with a spoon until they're 6 or 7 as being the cultural norm. But for a family such as this, that might be the case, and that might be very normal no matter whether they had a feeding problem or not. So it's just important to recognize when you're doing your assessment to ask about things that maybe you in your life experience in training and being brought up in the US might not even think about. To Sandy's point, seeing an actual feeding of a child being force fed, I saw it through a one-way mirror when the parents told me, we don't force feed at all, but then the grandmother was left with the child and it was a one-way mirror and the mom was out at the restroom, saw the force feeding happen. So you just need to make sure that you ask about it. And in this case, this boy had, an issue around vomiting, which was really tied very closely to force feeding his enzymes because they wanted to get them in and they were feeling that they couldn't, so they were just force feeding. So his response and reaction to that was to vomit. So that was definitely something we had to address. But what I do want to talk about for this is just that the approach of my treatment approach would be a combined parent behavioral therapy, so coaching the parents on how to handle the actual vomiting, how to handle trying to get him to take solid foods, but then also working with the patient himself to work on desensitization trials, which I'll show you some examples of and how we would do that to get them to expand their food repertoire. And in this particular individual's case, getting him to actually eat solid food again. He was fully capable of eating solid food, but he would not because he just preferred the bottle. So we really had to get him to come outside of his comfort zone with that. Really important in this situation for this case is to understand the cultural barriers that we're dealing with, the treatment barriers, and that we're trying to help a family understand that the way that is culturally congruent for them to feed their child may not be the most appropriate one in this situation. And you want to be able to do this in a very savvy way, which is to honor and understand the importance and actual correctness of their feeding approach for their situation. But in this particular child's medical condition, we have to do something very different because of their unique needs. But you want to honor the cultural approach and practice and not discount it at all and not put any value judgments on it and say it works for your daughter. The approach you did work perfectly for your daughter who didn't have feeding problems in this case, but it won't work in this situation because of his unique set of problems and challenges. And so we're going to try a really different approach and do something differently. So I had to approach it in that way. And then we had another issue here was there was an undiagnosed neurodevelopmental disorder. If you just surveyed us up here, we will tell you we have cases that we actually catch in the feeding clinic. When I worked in the growth and nutrition program at Boston Children's Hospital, many times I've had a child that was referred to me with complex medical issues and picky eating or refusal to transition from solids or full-blown avoidant restricted food intake disorder. No one had ever caught the neurodevelopmental disorder or the autism because they were so focused on the CF or the medical conditions or the other pieces of this child's presentation that took a back seat to the neurodevelopmental growth of that child. And really for this family, the family therapy approach is having to get in there and join with this family and provide the supportive things that were needed for this parent, this mother particularly, who was feeling quite isolated and really had a hard time, doing the medical recommendations. If you can imagine not speaking English in this situation, working through an interpreter, and having people say, you need to do this, this, and this, and having a patriarchal relationship with her husband where he was saying, you need to do this, this, and this, and the doctor said to do it, so you need to do it. And so there was a lot of anxiety and stress for her. So in order to make effective change in this situation, we had to support her, help her feel able to be competent as a parent and feeding this child again, and then really help supporting that with the frustrating process that she's in here. And I won't say it again, but culture matters. I'll talk a little bit more broadly about it overall of our treatment model. And my treatment approach is usually I am pulled in on a second tier. I usually am not the first person that sees a child. It's that they've been seen by a GI specialist or nutrition has seen this child and they're thinking, you need to go see Nancy. So in that case, I do my own assessment. I review all the medical records, but I do an in-depth clinical interview, and I'm really looking at feeding from birth, but I'm also looking at the parents' feelings and experiences with feeding. Many of the parents that I've had have feeding and eating disorders themselves that have not been addressed or were addressed but are sort of lingering in the background. I've had fathers with what's called orthorexia, which is a very restrictive eating pattern and excessive exercise and overly rigid feeding patterns, and that does not mesh well in this situation with the child that needs to be at a very high BMI relatively to that parent. Maybe the parent is coming in at a 10% BMI and the child needs to come in and really be a lot beefier than that, and that's a rub for them. So we want to kind of make sure we assess all that, parenting stress around feeding, making sure that they have all the oral motor skills that they need to. Is there a history of behavioral vomiting like there was in this case, and do I need to incorporate that into my treatment plan? And then I also want to be able to see the child's feeding in person or on video or in telemedicine if I had to do that, on video, on Zoom. And it was shocked to learn during COVID that I could actually do this kind of work remotely. It's not ideal in all cases, but it certainly did work for a number of my patients, and it was much better than not doing that. And then the other piece is just having a good standardized assessment that you could give to a family before you actually see them to help you target your interview and your clinical information you're gathering. And we have the one that we like up here, the Behavioral Pediatrics Feeding Assessment Scales in Young Children. That's probably the one that most of us use. I believe it's open source. You don't have to pay for it or anything like that. And the scoring is rather simple. You can even integrate it into your clinic paperwork that they can do online. So it's very helpful. That's really the first part. And then we get into the treatment piece, which is the phase of treatment where we set goals, we address behavioral barriers to feeding, and develop a working alliance. And this is really the first and foremost piece, is that you need to be able to instill hope in the family that the behavioral feeding can improve, that I know they've been told how to do things. You need to give your child more of this, you need to give your child more of this, but nobody's ever told them how, and that could be very frustrating. So I need to do a little repair work there in helping to develop a therapeutic alliance. And then we work on the food exposure trials, where I bring the child in and I practice eating the food with the child in different ways, and then I have the parent do it with me in the session, and I teach them and show them how to do it. And then I give them homework, and they have to go home and do parent-directed therapy. So the parent has to feel confident that they can then do that. And then I also help them along the way with how are they going to actually help the child learn to do this, and what rewards are we going to use, and how do you use a reward, and then all the behavioral teaching that you would use for any other kind of getting your kid to do their homework. How are you going to motivate that? So the same thing with eating foods that are going to help them with their overall health status. I need to use some behavioral techniques for that. And then the final phase is really getting them to be able to try a few foods with me, expand their food repertoire for just a few foods, and then to be able to spontaneously get over their fears and anxieties around foods and start to try things on their own. They see a friend eating something at snack and they say, hey mom, I want to try that. That's when I know that I'm getting towards the ends of my feeding treatment with them, and they're starting to do that. And then really a generalization is bringing things outside of my clinic setting, outside of the home setting, removing the rewards and having things become part of their normal life, and that's called the generalization phase. Normally treatment that's successful probably takes about 12 sessions at the minimum, and these sessions have to be spaced out by about 2 weeks. So it doesn't go well with a medical consult practice where you see a child once every 6 months or even once every 2 months is just not enough. You're going to have some way to beef it up or work with an outpatient provider. There are many cases where I work with kids that are followed by community providers. And so the community providers come to me, they come to the sessions, and then they practice the extra sessions outside of their time with me, because they live from far away and they can't come, or we just can't get them in the clinic as frequently as much. I feel it's important to say that, because sometimes I think we set people up for failure, that they think they're going to see me one time and their kid's going to leave there and be cured. That's just not the way that it works. It's a process, and it's much more of a collaborative process than many other kinds of psychological treatment. I want to kind of talk a little bit about, this mirrors what Dr. Severall was talking about with the proposed guidelines for feeding disorders. In this here, we have the DSM-5, which is the psychiatric diagnostic manual that psychologists and psychiatrists use to diagnose conditions. And in 2013, they revised our requirements to make a medical diagnosis for us of a feeding problem. And really, the individual has to have at least one of these four. I would say that most children that have CF that I treat have at least two of these. Certainly marked interference with psychosocial functioning, because they're not able to eat with their peers typically, or it creates a lot of stress in the family because they're not eating enough. But if you kind of look at the first one, which is the weight gain and significant weight loss, and then the second one of nutritional deficiencies, we have to adjust this for this population, right? It's not like my other kids that I see in the clinic, where if I get them to the 15th percentile, I'm done a good job, right? And I can discharge them because they're gonna be okay. In this case, we have to shoot much higher, and the threshold for involving someone like me into the care would be much lower, because when you have a kid that's sort of, we call circling the drain, where they really are at that 5th percentile or 25th percentile, even in some cases we've got to get that percentile up. You're going to need to pull out the big guns sooner in those cases. And when you hear about kind of some of the behavioral things like behavioral vomiting or force feeding, and the child's not taking the enzymes, like that's when I would trigger a referral to somebody like myself. The other piece that's important to this diagnosis, and I say this because I think people don't understand that you can have other kinds of eating disorders with an avoidant restricted food intake disorder. Really, avoidant food intake disorder is different from any other kind of feeding problem because eating disorder like anorexia, bulimia, because there's no sense that they don't like their body, there's no body dysmorphism, there's no wanting to eat less to lose weight or to be skinny. Those factors make this inherently different. We don't typically see that in our young CF patients, but you could see that as an adolescent, male or female, becomes, pre-adolescent to adolescent. I've seen these kinds of statements by the child at about 9 years of age starting and then going up from there. And some people are shocked when I say that, but I certainly have seen it, and I've even seen it in some younger kids, but it's more the norm when they get to be about 10, 11, 12, particularly when their bodies are changing. And don't just think it's boys or girls. That it's just girls and boys couldn't have this. You absolutely see it in boys as well. And also the other piece is that it can't be due to lack of food or poverty is the other piece that, that first one really gets at the poverty piece, which is that there's not good food choices available to this family because of poverty. This cannot be because of that. It wouldn't meet criterion. And then the bottom part, which is if the feeding disturbance occurs within a medical condition, that it's sufficient to require independent clinical attention. Well, if they've got referred to me and they've gotten in my door, they meet that criterion too. So the overview of different types of treatment that you're talking about, I've talked about sort of the type of practice that I use and that a lot of people that I work with use, which is more of a family-based therapy where we're using desensitization, but I want you to know other ones that are out there, which I just described, the family-based model. Individual therapy and CBT exposure therapy. So you can have an older child who has a genuine fear of vomiting or a fear of eating foods or getting fat or all sorts of things that you might have fear around eating a food that they just don't like, that they're afraid of. And then you can use cognitive behavioral therapy, which helps the child then do exposure therapy, which is they address their cognitive triangle, which is their thoughts that they have about the food or about eating, and then the feeling that's evoked by that, and the behavior, which is not eating. And then we try to readjust that flow of that triangle to have a more adaptive thought or a positive thought, and then the better emotions that go with it, and then food acceptance is the behavior that we're looking at in that one. And then we have what's called ABA, which was specifically an autism spectrum disorder specific treatment, but is also being used for lots of kids with neurodevelopmental disorders, genetic conditions that have intellectual disability with them as well. And those things are not exclusive, to kids that have CF. You could have a kid with CF and any number of neurodevelopmental disorders. You need to know about this. These services are typically very intense, 20 hours a week sometimes they're less depending on the resources in the area, but most states have mandated insurance coverage for this, as well as other providers have been trained in it, such as school providers. And you can have IEP goals about feeding for this child. It's part of their medical condition that keeps them in school, and it's an adaptive skill, which is another way that I get it on an IEP, saying that they need this adaptive skill to function for a child that has intellectual disability, just let's say. So the ABA approach is a much different model where we have somebody working with them using operant behavioral conditioning, and they work with them to try to get them to approach different things. And usually it's around play or eye contact or talking, but we can also do it around feeding and feeding yourself and accepting new foods. Other treatment modalities would be reinforcing behaviors that promote good food intake and feeding skill building. I'll kind of talk about those. I have some nice slides at the end that I hope will be helpful for you about consultation in your office, that you say you're a nutritionist and you don't have a chance to get them to see a psychologist anytime soon. I have a whole list of things that you can be counseling them on for feeding behaviors that get in the way of feeding. Desensitization food game, I'm going to go over this. This is for kids that have aversions or fears or over selectivity of eating. I talked a little bit about the cognitive behavioral therapy and the ABA. And then escape extinction is something that's used in more behaviorally based centers, typically inpatient settings like Kennedy Krieger in Baltimore. And so what they do is it's a much more aggressive model of behavioral therapy, and it's used much more for individuals with neurodevelopmental disorders and intellectual disability. I do not do it. It is more on the side of what I would consider aversive treatment, where you have a child at a table, and in order for them to leave the table, they have to put something into their mouth. And so they call it escape extinction, so you're extinguishing the escape from the table. But it's not a model that I typically practice. But in some very extreme cases, if you're dealing with a kid that's very at risk medically, and nothing else has worked, that might be an inpatient approach that people pursue. And I know that we've done that with some of our patients because it was a last resort. This is a great little visual that I use with a lot of my patients, and this is something that you can create with your own family and friends. This is my godson. He's now 10 years old, going on 11, but I use this all the time. And what this does is it helps a child understand what we're asking them to do. We're not going to bring a plate of food and ask you to eat the whole thing. We just want you to try something for the first time. And we break it down, and it's a visual preview, which if you do any kind of anxiety work in your medicine, you'll know that previewing any condition, any procedure, any sort of thing that the child's going to go through is going to reduce their anxiety. But it's also modeling, because he gets to see this little boy doing it, and hey, that kind of looks like somebody I know in my class. And the kids ask me all sorts of questions like, how old is that boy? What is his name? What does he do? And one of my kids who was on the spectrum, it was so cute. So he added to this little list of his hierarchy, hold, smell, kiss, lick, and bite. He said, well, first you have to hear the apple, because my little nephew is holding it up next to his ear. So he put that up there. So they relate to it, is my point. And then they take it home. I have these laminated. I'll give them out like candy in my office and say, please bring this out at mealtimes. And the kids will get it themselves, and it's just sort of a way for them to know. And when we're doing desensitization, I don't have to do all the steps on the first desensitization to get a reward. I can stop with just holding it for a very highly anxious child, and then the next day we do holding, smelling, and kissing. And guess what? If you kiss it, you get it on your lips, and what do most kids do? They lick their lips, and then by then they've already started tasting the food. So I just reward each step until I get through this, and then we get to the bigger bites and things. I'm going to give you some video examples of how me doing treatment with some different kids, and this is actually the same kid. A quick overview of this case is a boy. He is on the spectrum, very, very bright boy who has great language, but very rigid. He ate only applesauce, vanilla Oreo cookies, milk, lots of it, way too much of it, and maybe one other thing, and that was it. And he had a hypersensitive gag reflex to the point where I don't know that I've ever seen this before. I had a complete GI workup, nothing was going on. Everybody under the sun said medically there's nothing going on. It's all up here and probably related to his sensory aversions because of his autism spectrum disorder. And in this case, I'm teaching him how to control his gag reflex and not vomit. Because anytime we put a new food in his mouth or any food that he was not familiar with, he would immediately vomit. It would be outside of his control. So I'm using a reward system here. If he's able to do the food trials with me, he's able to play a game on PBS Kids on my computer. So you'll hear him talking about this. But this is just me doing deep breathing with him.
Okay, say I'm okay. Say I'm okay.
I'm okay.
Let's wait. Say I'm okay.
I'm okay.
Can you breathe in through your nose? No, in through your nose and out through your mouth. Try that. In through your nose and out through your mouth. Good job. Okay, are you all ready for the next bite? Okay. Remember, stay calm and send it to your belly.
Yeah, that's 2.
That'll be number 2. That side right there will be number 2.
Now the last one.
And then that'll be 3. Okay? Take a bite. Stay calm. You can do it. Stay calm.
You see him panic there. He's panicking. And he's getting anxious. He's trying to hold it down.
Way to go. Good job.
You got it.
You're all right. You're all right.
It's okay.
No big deal. No big
It's all right,
deal.
honey. It's all right.
No big deal.
This isn't good. How can we play a computer?
You totally can. You totally can.
Yay! What?
So you saw him trying his hardest to stay calm and to use his emotional coping to keep himself okay, but it still came up anyways. And you want to shape the child to know that they did a good job with that part, and the next time they'll get it, and not to feel stressed out by having that little bit that did come up. And he is doing so great. Now you'll see him on the next slide where he's older. He probably does not need to see me much anymore. He eats a great diet. But this is him when he's older. And you'll see the rigidity around that you'll see with kids, and this is not just a spectrum-y kind of thing. With kids that have avoidant restrictive food intake disorder, they're oftentimes like nitpicking the food, and you'll see me addressing that in the next slide.
Which one do you want to do first? The turkey? So Henry, look at me. Let's stop. Look at me. Hold on. Slow down. Eyes. Okay. Calm, calm, calm. Let's try again.
You distracted me.
I did.
I needed peaceful and quiet to do this thing.
Okay.
Let me touch. Okay. Nah, bigger.
Okay, you pick one or I'm gonna pick
So what he's doing
okay?
is he's grabbing the perfect piece that doesn't have any black marks or like things on it.
Good job. Now I'm gonna pick one for you, okay? Let's do that one now.
Oh, not gonna drop it. I'm just not gonna eat this part.
What's wrong with that part?
It has the brown edge.
You know what, you're gonna eat it anyways, because you need to get used to being flexible and eating brown things too. Awesome, look, you did it. You were totally able to do it, no problems. You were the boss.
So what I did there is very gently tell him a different narrative around the food, that in the past his mother, wanting to just get him to eat whatever food she could, would give him the pieces that he wanted and pick off all the edges and make sure it was perfect. And I'm challenging him to think about this in a different way and just say, okay, it's okay to eat food that doesn't look exactly the same, and you are going to be okay. And I'm a little assertive with it, but I have a relationship with him, and he trusts me, and we've been working on this for a while, he likes coming to see me. He's very excited. He was sad one day when he came and he had the flu, and he had to go home. He got sick on the way to my appointment, but they just came in to tell me that he couldn't be there, and he was like, I'm so sorry, I can't see you today. You know, so even though I'm making him do hard things, he likes to come.
You're gonna do it. You're gonna be awesome. Stay. Chew and swallow. Awesome. Way to go. Okay.
So what? I think we should do the.
I'll let you pick. Okay. You wanna do the peeling? I'd like you to do the peeling, okay?
So I make them do the peeling because I want them to get used to the
No.
way it feels and smells before they eat it. Because a lot of times kids won't do foods that they're unfamiliar with, so just touching the food is a very important step. Okay, so we'll stop there on him. So now these are the things where I'm gonna give you hopefully some ways to understand this that'll help you when you're doing consultation with a patient. So you have a patient that comes in and you have food refusal. They just, I make food and then they don't eat it, and I end up having to go back and make 5 other things, and then ultimately he ends up eating, Oreo cookies, the vanilla Oreo cookies in this case, right? So what happens here is you have food refusal. The kid doesn't want to eat something for whatever reason, and then the parent goes back and does what I call short order cooking, going through the repertoire of making whatever they think the child will do, and then we behaviorally rewarded picky eating. So we want to break that cycle. The other often presentation that I have is a toddler no. So that's very normal, right? Everybody that's had a toddler knows that there's a time when no is their favorite word, and you should expect that, and it's actually developmentally ideal. You want a kid to say no to you because you want him to understand that that's an option for them, and that it's a normal part of development. But if a parent can't accept that, particularly if they're afraid of their child not being okay medically, remember this is normal. Like if you were in their shoes, you probably would be feeling that same way too. So not accepting it is it's not an option for the child not to eat. Then it gets a child into a power struggle with their parent, and then you're off the rails and you need a consultation with someone. So you want to talk them through that, saying, even though you're having those fears and anxieties about your child's intake, you have to stay calm, you have to regulate your emotions, you have to project a calm a calm attitude to your child, and you have to try these different strategies to get them to try the food. The other one is gagging and vomiting when food is presented, and in the case of the child that we talked about earlier, our case example, it was just when he got when he had a tantrum, so when he became emotionally upset. So for him, you could pretty much never say no to him because he would vomit, and then he would lose all his enzymes, or he'd lose all of the medicine that he'd been given that day or whatever. So they just basically gave him whatever he wanted. So we have to work through the limit setting as a normal part of life. You have to learn how to accept no. So it's a form of food refusal. Really, in this case, we have the medical concerns that have to be addressed. And really, when we remove those foods that the child's are making them vomit or gag when they see it, then we're rewarding the gagging and vomiting. So that means rewarding means making it stay longer. So we have to figure a way to get them to exposed to it so they can get over it. And then tantruming and other avoidance behaviors at mealtimes, you may need to refer them or help them with some resources on parent limit setting. There's lots of resources, especially at like cdc.gov about parent guidance and limit setting and tantrums. There's lots of places where you can get resources. So you have to assess, do you ever say no to your child? And I, more often than my CF patients, the case is no. I had a family that was literally living just on a shoestring budget, but they went to one of the most expensive takeout restaurants every night and got the kid this lasagna that he wanted, which was delicious. I mean, we'd all love it, right? But they didn't have the money for this, but that's the one sure food that the child would eat, and she did it. And the one big one that comes up is throwing food, and so particularly with toddlers. So it has three main functions. I just want you guys to all know this. It's fun to watch the food fly and splatter, so it's a game, right? It's a form of food refusal, and it also is rewarded by the behavioral reaction from the parents. So the behavior itself elicits a reaction from the parents, and then the parents have a dramatic response, and then it behaviorally reinforces the throwing, and then it happens over. So we have to circumvent that cycle of rewarding to get the behavior to go away. A lot of times people will say they're told by their early intervention providers that if the child throws the food, it means they're done with the meal. It could be, but it could also be that they know that when they do that, they get to get down from the table and go play with the trains over there, but they should really rather do that than eat, but it doesn't mean they're not hungry, right? It just means they have something else they like, or they have attention span of a toddler, which they do. So you don't want to misinterpret through throwing behavior, meaning that the meal should end at that time. Ellen Satter's work is instrumental, pivotal, seminal to all of us who do this kind of work. And really what she does, she has a great website you can go to, and particularly for kids with CF, difficulty meeting their goals, and then the parents then need extra support to deal with this. So the parent goals are very clear over here. The parent chooses the food, they provide regular meals and snacks, they make meal times pleasant, they give examples of the child eating the food, and they don't offer beverages or foods between meals, so they allow the child to develop hunger, and they let the child get to grow up and figure out what feels right for them in their bodies. You can't always do that with a kid with CF, because maybe what feels right to them is the 15th or 20th percentile, because that's genetically where their parents are, but we can't stay there, right? And the child's jobs are that they're going to eat, and they need to do the part. You can't make somebody eat, you can't make them poop, you can't make them go to sleep. Those are things that are important to remember. As much as the parent tries, cajoles, coerces, they're not going to be able to do that. So defining these things, and where the parents need to set the boundaries of what they can do. They can provide rewards for reaching goals and things like that, but it's up to the child to choose those rewards. So other consultation and guidance that might be helpful for you is, the kid I call them the drive-by feeders. So it's kind of like they're on a bicycle, or they're not really on a bicycle, obviously, but they're walking around and they come by to the table and eat a little bit, and then they go wander around and play, and then they eat a little bit more, and then they eat a little bit more. And what's happened there is the parent is so stressed about getting the caloric intake into the child that they don't make the child sit for the meals. And so the meals end up going on really much longer than they need to, and the intake is poor. So you want to teach the child to actually sit for meals whenever possible, We want to eliminate distractions whenever possible. I can tell you that I've had many children who have never been fed without an iPad. And so do not just say cold turkey, no more iPad, right? So what you do is you sort of fade it out where they have to eat for a few bites before the iPad's introduced, and then a few more bites, and then the iPad's introduced, and then a few more bites, and then the iPad's introduced, and then after 5 minutes the iPad's introduced, and then they get the iPad at the end after they've done their feeding time. So you fade it to the end. That's a common thing. The other common thing is just meal times. How you have to ask, how long are your meal times? If they are over 30 minutes, you have a problem because they won't be able to have enough time in between the meals to get their appetite up, and they will, if they're drinking between meals, they're grazing on liquids like juice or soda or milk, that's a problem. So the average meal time for a 2-year-old, anybody know? Supposed to be 17 minutes was an average on a study that was done. So think about these families that come in 60 minutes, 45-minute meals. It's not going to be, you're going to have behavioral problems once you get that long. So shorten the meals. We want to promote family meals whenever possible, but it may be too stressful and unrealistic for families, so you don't want to set them up for failure. Another thing I have is in culturally or even just busy scheduled families where parents are coming home at different hours, parents who are in law enforcement or parents who are nursing and are working shift work, or a father who's driving Uber and comes in at different times. The kids oftentimes won't get to eat with their father or mother or parents at all. They'll be just with the grandparents. So if it's possible to have family meal times where they have a snack with the parent or they have dessert when the parent gets home at 8 o'clock just before bed, those are things you can do so that there's that family meal piece, but you have to think creatively about that. Some more things that I wanted to kind of just help you is like removing the behavioral component to the end of mealtime. So a lot of times what I do with this is like, if we want the child to instead of tantruming to get out of the chair and be done with meal times, we set a timer or we play music for 15 minutes, and then when it's over, you're free to get up from the table and do whatever you want to do. But the job is that you need to be able to do that, and we can give sticker charts or rewards for doing that sitting at the table. We want to make sure that we develop a behavioral plan to address any disruptive mealtimes behavior, big tantrums, aggression, other kinds of things that come in for some of our kids at mealtime. So we want to deal with that as we would any other behavioral problem. We want to stop coercive force feeding patterns such as force feeding, or like I had one parent that in her desperation, and my heart goes out to her for doing this, but she literally would lock herself in the bathroom and cry, and she said, "I'm only coming out if you eat your food." And she was so desperate and so at her wit's end, she did not know what to do. And so he didn't want his mommy to cry, so then he would eat. So you don't want to get in that situation, and you just have to ask those questions if those things are really happening, because no judgment, no shame on sharing it. It's just okay, so understand why they did it. And then say, okay, so over time we want to change this to more of an independent eating, which is for him to learn to do it on his own without you having to do that step for him. And sort of, there's no judgment in that. That is just where we need to move the child. Letting parents know what a typical intake looks like. Many parents set their kids up for failure by piling it on like the buffet style, like giant plates of food like you'd have at Thanksgiving, and they expect their kid to eat that, and the kid looks at it and freaks out and runs away from the table. So those are definitely some things that are important, and I want to give time for questions, but parent-directed food exposure would be specialized with someone like this. Occupational therapy for people who have sensory issues, where there's like can't feel, touch, and they have trouble with the chewing. And then SLP for swallowing difficulties and other sensory-based feeding disorders. You guys have some great, if you're from the Philly area, you have some great clinics here in town. There's also some resources that we'll be giving you here that are in the slides, but I just want to point out, I think these are ones that are more articles, but there's more. Ellen Satter's up here. Feeding Matters is fantastic because it has local resources no matter where you are. And this is in your slides, which I think you guys have access to as part of the conference. but it's just feedingmatters.org, and that's a whole list of people that come together that do what we do and have resources and connections of providers in your community. And I believe that's time for questions.
Say what you do and I'll say what I do. Okay.
So a question here. If force feeding was introduced for taking enzymes, how would you coach the parents and other helpful techniques to break the cycle without affecting CF consequences for not taking enzymes? So for my example that I discussed earlier, it was actually pretty good. It worked out really well for me because when I saw that, I just gently asked her. I said, "Oh, do you mind if I help you with that? You seem to be, so that let me take over. Let me help you." And so what I did is I actually started playing with the applesauce with the child, and I said, "Oh, look at the applesauce. It's so fun." And I said, you can put it in your lips, you can put it in your nose. And he was really smiling at me and going, "Hey, I can do this." He was actually pretty engaged. And I said, "Well, now let's use the spoon." And I did the same thing with the spoon. And I said, "Oh, can I poke you with it? I'm going to poke your nose." And then eventually I said, "Okay, now we got to open wide and take the enzyme." And I don't know, it worked like a charm. And I can't say that I will say that works every time. It may not. But it worked with that situation where it was just a gentle moving up the hierarchy. And it didn't take longer than like 3 minutes. It was just kind of like a little process. But in that situation, it was just, again, going up the steps of eating.
So I love that approach. I think that's very much a playful approach where you are the therapist, you're the rewarding person with the child. What I would do is something very similar to that. I might use that food game, but with a spoon with enzymes on it, so that they're doing the food exercise with rewards. I would not tell the family to stop force feeding all cold turkey, because if they can't get any enzymes into their child and they know that the child's not going to be well because of that, it's too stressful. No parent in their right mind is going to be able to leave that session and do it. I also would do what Sandy does, but I'd also have the parent take over, and I'd change places, and then I'd coach the mom or dad on how to do it. Do you want to add anything? The low cognition one, do you want me to do something? Yeah. So the low cognition, when there's the question here is, how would you handle this behavioral feeding with childs that have intellectual disability or low cognition? The child's not toilet trained and those sorts of things. I absolutely treat kids like this with feeding disorders. I use more of an ABA approach with them. I use visuals for them because in the case of our example, I couldn't explain to him the process of doing the feeding exposure, but when we have the visual that I had for him, it breaks it down. He has a picture of it. He doesn't need to have the language to know what it is. And then he can copy it and he can do it. So you need to make it meaningful for them. You use a lot of positive social reinforcement, tickles and praise and really kind of excited affect when you're working with them, trying to get them to shape them into doing whatever task you're asking them to do with feeding. But it certainly works, and I don't think the piece that doesn't work so well is the cognitive pieces, is changing your thoughts and feelings about the food you're afraid of. That's a much more difficult approach. For kids that have sort of a low but verbal, they're verbal kids, but they have low cognition, I'll use social stories, which kind of talk about how you feel about the food in a very simple terms and how you go about trying new food. So I use some visuals, social stories, other sorts of things. Some more questions. The medical? Oh, okay. So this will be really fast. The question is about, which one is it? Where's words? Oh, what kind of rewards do you use for your behavioral approach as they begin trying new foods? If so, what rewards do you suggest? So I would tell you that a reward is different for every child. And a reward, if you're a behavioral person, if you've taken any behavioral psych courses, a reward is anything that increases the frequency of the behavior or the targeted behavior. So there's no secret to it, right? I wouldn't start with a token or stickers. For most of my kids, it usually has to be a very immediate, you do something and then you get something that you like. It could be a wind-up toy. It could be something they're excited by. In some cases, particularly when I don't have a great, like for the kids with intellectual disability, I might be more often using a preferred food. I've used a if-thens placemat with like, first you do this, try the food, and then you get this, which is their favorite show on a phone. I get to start the video for them, and they like that. So the idea with rewards is something that's meaningful for the child. You probably need to have at least 3 or 4 different rewards and rotate them. Once a reward stops working, meaning that the child's no longer motivated by it, you need to do a reinforcer assessment, see what else they might like, and try to change it. Don't always use the same reward because they'll get burnt out and it won't be rewarding anymore. Change it up as much as you can. When a kid is older, like 6, 7, 8 intellectually, you can start to use tokens and other sorts of things, and use, meaning that you earn 5 stars and then you can go to Starbucks and get hot chocolate with your mom or something like that. But not until a child's much older would you use a token system like that. Okay, so the question is, what is your response to a parent who thinks you're telling them to be mean to their children for following the division of responsibilities? I think it's all in the framing of it, and that I kind of would shift that to say that your job as a parent is to teach your child some independence around their feeding. And so we're going to gradually start to have the child do more things for themselves, so they don't have to adopt that division of responsibilities right off the bat, but gradually they're going to push those things onto the child's side of the equation. And I would talk more about it as the parent as the teacher, that they're really gently showing them and kindly showing them. And I might also model and say that, I know this sometimes this limit setting kind of thing might be hard, but in some respects, you're actually making the child feel better about things, because when you do set a limit, they feel safer, they know where the boundaries are, and their anxiety goes down, particularly around feeding. So I talk about it as a process, and I don't think I've ever had a family say that I'm mean about it, but they may tell me, I don't know if I can do that, and then we flesh out why they feel they can't do it. I hope that answers your question. Yeah. So this is a really great question. There is no feeding clinic that is close by, and it's a child that would benefit from specialized care. What would be a better referral? Behavioral family therapy or OT for sensory behaviors for the parent? For the child. So I would say it depends on the child's presentation. If they're a very sensory averse child that really needs somebody to help them get over their fear of mushy foods or any kind of textures, then I would go the OT route. If there's lots and lots of behavioral family stuff going on, or the child's highly anxious, parent-directed treatments like behavioral family therapy are really probably the way to go, because once you deal with those things, the other pieces might sort of fall into place. I'd also say that look at the Feeding Matters website, look for people who are doing telemedicine consults, who can work with local providers to give the consultation, even if it's a 45-minute consultation with a specialist like myself that consults with a team that might get a family where they need to be, or a treatment group that doesn't have sort of feeding therapy resources on the path. I work with ABA providers all the time, kids that have autism. Maybe the ABA provider doesn't know the first thing about feeding. I just set up the program and send it on their way. So they might just need a consultation with someone briefly to work with their treatment team close to them. There's also great parent workshops online and SOS for parents. There's a SOS feeding. The parents can go to these workshops that are also given virtually now. So the parent as the therapist is also an option.
The only other thing I wanted to say, just with regards to what Nancy just said, I agree with everything she said. I think there's been a great mental health crisis with the pandemic, and we know that there's a shortage of psychologists and people that can focus on child behavior. So understanding that that's very stressful, we have, I think as a CF community, it's important to just reach out to your colleagues with these consultation questions. I know at Boston Children's Hospital, we actually do have, and I know other tertiary care institutions have it as well, but we do telehealth, like telemedicine consultations, and there's like a process to go through where we review records and help with these kinds of cases. So if that comes up, like, please don't hesitate to reach out to centers that actually have the ability to have more resources around this.
So that concludes our presentation today. Thank you guys for coming.